Hello and a very warm welcome to you. My name is Ray Lavery.
My name is Jessica Crooks.
And together we manage and run Trans Matters Worldwide and Trans London Meetup Group.
We do in-person events and online events once or twice a month. And right now we're hoping to move into webinars. We're bringing in experts and trying to educate.
That's it. And so originally this channel was actually my female to male transition line, but we have upgraded it from there. And as Jess has said, what we are going to do is we are going to do all things transgender. So there'll be fresh webinars, there'll be fresh interviews, there'll be some fun stuff if we can think about it and just record it, and things just to keep you occupied and have some fun and help you along your transgender journey. So to make sure that you don't miss out on anything, all you have to do is hit the subscribe button, and that way you will get all of the notifications of what we have coming up and you won't miss out on anything. So enjoy that and we will see you in there. So take care and goodbye. All right, the recording is in progress. You are all extremely welcome today to join us for this very rare, and frankly, I'm not sure how many people do webinars like this, but we are delighted anyway to have you here. You're very welcome. My name is Ray Lavery. With me here is the wonderful Jess Crooks. Jess and I together, we run a meetup group, which is the Trans London Meetup, and we also are sort of migrating very slowly towards the Trans Matter Worldwide, which would be an entire platform that we're building with loads of resources for trans people all across the world, regardless of how it is that you identify. We're kind of dipping our toe in the water with these webinars. We get a lot of questions and a lot of requests, and so we thought rather than us just give the answers, that we get a bunch of experts in to answer the most commonly asked questions that you have and to give you a resource that you're basically able to use moving forward. We record them so they go up on YouTube in case you missed the live stuff, and that worked very well because we get hundreds of views on these webinars afterwards, which is super. So today we are delighted to have the wonderful Mary Burke with us. Mary has already done a wonderful webinar on hormones for MTFs. It was very well received. We've got some amazing feedback on that. So again, thank you for that, Mary. That's absolutely wonderful. Today we're going to deal with FTM. Okay, so the other direction. And this is last time Jess was the one with all the knowledge. This time I think I have a little bit more knowledge on this one, but none of us have as much knowledge as Mary Burke. So Mary, do you want to do an introduction to yourself, or do you want to?
It could go on forever because I like to talk. So you're very welcome to stop me at any time. It's funny how life brings you to the kind of end story, and my story actually in many ways is only beginning. But I did my general nurse training in Dublin, my midwifery in Manchester. I studied acupuncture and Chinese herbal medicine for 3-4 years. And I ended up working in general practice and then going back to midwifery. 2009, I started working with the London Transgender Clinic, not known as it then, but I was introduced to transgender individuals, and I started to learn a lot more. But I had also done my prescribing in 2008, 2009, and I'd always worked in women's health and hormone therapy. In 2017, I was approached by a very well-renowned NHS psychologist who was going into private practice, and she asked me if I'd start seeing her patients. Actually, that was 2016, and that's when I did, because there was so much overlap between what I had learned over so many years, and working with transgender patients is just so rewarding. I mean, I love every single one of them, and I'm passionate about what I do, to enable patients to access care in a timely manner is a real privilege, because we know the waiting times are difficult. So, I love my work. I'm not an expert. I don't know everything, but, I know enough, and I'm a safe, sensible practitioner. And when I don't know the answers, I will put my hands up and say, you know what, guys, I'll get back to you. Or I'll bring you to someone who maybe does have the answers, or I'll refer you back to your GP for a referral to a consultant cardiologist if you need the okay, a hepatologist. We've had a patient recently with complications on a liver transplant waiting list. But with the consultant hepatologist, we've managed to manage their care safely. And that's what we do. And it's a nurse-led clinic. We have MDTs with psychiatrists, surgeons, and psychologists. But you know what? My job is to make it possible for every single, patient that comes into our clinic to access care safely. And we love doing what we do, and we have fun doing it.
And it's great that you have fun doing it as well. It's also marvelous to see how you're able to work things around for everybody, regardless of how the complexity of the cases that you're facing, is that you're able to find a solution for people. And I love that, because too many of the computer says no kind of attitudes out there. So it's amazing to see that that's not your attitude.
We have never, ever once not been able to enable a patient to access care safely. Now, sometimes it may take time, but we've never not been able to do that.
Amazing. Absolutely amazing. So what we're going to do, Mary, is we have a load of questions already, and I know that, and I can see Jess is already typing in the chat here. But I just want to say to anybody sort of listening to this right now, if you have a question, a lot of you have already figured this out, you can put your questions either in the Q&A or in the chat, and we will systematically get to them. Okay, so Jess will be monitoring all of that, and she'll be asking the questions, and she'll interrupt us all, because myself and Mary, we could just keep talking forever. Like,
surprise to surprise, I have slightly less questions for this webinar than I did the last one, just slightly less.
However, I have quite a few questions for this one, so it'll all even out. Now, if you are watching the recording, as I'm just going to say this, I know you're watching this live at the moment, but if you are watching the recording of this on YouTube and you have a question that's not answered, put it in the comments and we will still get your question answered. Okay, so just to say that it's very simple and very straightforward. So I can tell you, Mary, that the lead up to going on hormones is one of the scariest things that you will ever face. The doubt, the questioning, the idea that the second you put another hormone in your body, that your life is going to explode, is pretty much in the forefront of your mind. It is a scary, scary thing. Now, I just want to state for anybody watching this, that was, I tortured myself for about 9 months before I actually went on to any hormones, and I got almost no sleep, and am I ruining my life and all of this kind of stuff. That was like the sort of the norm. The second I went on to hormones, all of that madness disappeared and went out the door. Okay. Because I realized that my world wasn't going to explode. Life just generally just go on as normal. And the changes that you see take place over time. And I would like to stress the over time bit. And I know we're going to be talking a little bit more about that. But so I'm going to be giving you my experience, because I'm pretty much just 2 years on testosterone now. And I've had the normal seesaws that everybody has had. But what I wanted to do is I want to get some of the basic questions out of the way, and then we'll go to the audience to answer their questions as well. Okay, now, when it comes to FTM, what is the story when it comes to hormones? Like, what are the basic hormones that you can take? And I guess second question after that, what would be the process to get onto these hormones?
Okay, well, the process is in the UK at the moment that you need a diagnosis from a psychologist or a psychiatrist, and preferably probably a psychologist, well, absolutely, who's HCPC registered and who has maybe some knowledge of the treatment and the diagnosis of gender dysphoria. That's the way it stands in the UK at the moment. Okay, in order to access, I have to, with it being a nurse-led clinic, I have to make sure that every patient's diagnosis, otherwise I wouldn't be allowed to practice. Do I think that's necessary, essential for everyone? Well, I have an opinion, might as well keep it to myself on that one. But, once the diagnosis is made and they're referred to our clinic, we will do an hour long, we do Google Meet, and we take a history, because we don't want to bring the patients in and then they're sitting here in front of you and you can't prescribe, you can't go on. We get all the information, we get a medical summary from the GP, and then we have a conversation. And when patients come into clinic, then at that stage, we've checked their bloods, we know that everything is okay. And that can be 4 to 6 weeks later. And then, you know, we check their blood pressure. We do an in-body analysis, a great old machine here. You must come in actually, Ray, and get on it someday. Quite surprising what you might find out about yourself. But, you know, and it's really, you know, it's really nice. And it's a safe place, you know, where patients can ask any question they like, where they feel quite at home. I'm very open, I'm very honest. With my patients, I do scare some of them on occasions if they don't do as I ask, but it's all part of the process and part of forming a trust and a bond, so patients feel they can open up. And then from there, I will always start patients. There's different forms of testosterone, you know, we all know that, but it's a hugely powerful hormone. And if you think that, you know, as an assigned female at birth, your testosterone level is normally under 2. You know, starting on testosterone, your level can go up 15, you know, 20, you know, sometimes 30 times if your T level is 1. That's a lot. And with it being a powerful hormone, you don't know patients who may have mental health issues. You know, with lots of my patients have history of depression, anxiety, because of the struggles with the dysphoria they've gone through. Sometimes you have to be careful. You have to assess your patients. I mean, and what I've learned over the last 5 or 6 years, and it's wonderful that we have a wonderful psychiatrist who work in psychologists, and we have MDTs every 3 weeks, so we can bring conversations to the table. But patients with a history of psychosis, oh my goodness, okay, you really have to go slow. But, you know, I've only had 2 patients with that kind of history that we have to kind of be very, very careful with. 99% of patients, you know, they get on it, everything starts to change. And you're right, Ray, what you said. Everyone does it in their own time. It's like anyone's puberty. You know, it's very different. But I will start for safety reasons. I initially, when I started prescribing back in 2016, 17, you know, I would consider Testosterone because it was something the NHS did. Now I don't. And actually it's just as bloody well, because now it's difficult to get. And I know we'll have that conversation later, but I start everyone on Testogel. It's a transdermal, actually, I have a bottle here somewhere, an empty one that I just show to patients so they can see, you know, what it is they're getting, what it is they need to do. But I start everyone on the transdermal, because if you do get a reaction, okay, because it's a powerful hormone, you can very easily adjust your dose, you know, to slow things down so you get used to it, you know. And more is not always more. More is sometimes less, and you end up, and too much, if your testosterone level is too high, it can convert to estrogen.
We have a question from Rian, who's looking to start testosterone soon, within the next month. They're saying, is there a recommendation to start on a higher dose, a mid dose, a low dose? Let's see how you go.
No, it very much depends on the individual. And as I say, I start everyone, Jess, on the gel. All right. And generally we'd start on the pump. It comes, 1 compression equals 20.25 milligrams. So I generally start, you know, anyone who's absolutely stable, not an issue, we start them on 2 compressions, 40.5 milligrams a day. You know, anyone who's, you know, struggling a little, you know, and there's many reasons why patients struggle. But, you know, sometimes we say to them, look, do you know what? Just do the 1 compression for the first 4 weeks, and we'll give you a phone call, catch up, make sure everything is okay. And if it is, then, you know, you can up your dose. We stay in touch with them. I mean, there's one patient, one of the girls has been ringing weekly for the last 3 months just to catch up, and they're doing fine. But it's just to have that support and know that there's someone there, you know, if you need it. But one size does not fit all. And I would not prescribe, like I wouldn't start a patient. I know in Scotland, they'll often start patients on Libido, which is the slow release, long acting. And I love
on Libido on day 1.
Yes.
Really?
Yes.
Wow.
Yes. Now, I don't want a mad rush heading to Scotland. Okay, but
no, don't do that.
No, but no, but you know, it's all about, you know, practitioners and their experience, you know, and like I wouldn't do it because, you know, once you inject a substance, if you're going to have problems, then, you know, what do you do? Whereas if it's a transdermal gel, I always say, look, I'm not having a discussion with you. Okay, this is what I'm recommending. You can take it or leave it. I was going to say something else. You can take it or leave it, okay? But just for the first 6 months, and then we can have a conversation, because sometimes Testosterone will not suppress, you know, the menstrual cycle. And, you know, if you have a young trans male patient, they don't want to be worried about regular monthly awfuls. You know, they want to stop it. Well, absolutely. 80 to 90% of patients you put on libido will stop menstruating. But I need to know first and foremost that you're going to be safe. And the other thing is, if you're prescribing and you're asking a GP to share care with you, if you're prescribing a transdermal testosterone, you know, it's more likely that they're going to start prescribing. So then at 6 months, if you say, well, actually, this is the reason why we now need to move on to an injectable, slow release, long acting, they're more likely to, because at that stage, the patient is stable. So you're actually enabling a patient to have long-term care, you know, with the GP.
Yeah. So can I just personal experience on this? Now, as we have already said, everybody's experience is different. Okay. The worst thing that you can do is be on YouTube watching all the bloody timelines as to, well, I grew a beard by 3 months. No, you didn't. No, you didn't. You know, everybody's different. Do not try and match yourself to how everybody else does. You are getting only 2% of the reality of being on this. Now, when I started being older, much older, to a point where I was told, we don't know if this is going to work on you, it works. They were like, and I also wanted to start on a, not a micro dose, but a lower dose, simply because I didn't want a thing called vocal entrapment. If you put too much testosterone in one go, it squeezes your vocal box and you basically end up sounding like a gay man. So if your voice changes too fast, you sound squeaky, and you can never fix that. So although there's not a lot of documentation on it, there have been studies done on this that have really, their PhD studies that have been done on it. And they're saying that if you go for a lower dose over time, and then once you're about a year, you can start ramping it up, then that gives your voice a chance to, your voice box, if you like, a chance to accommodate this. And as you can hear, it's worked. Now, I did not pass on the, you know, vocally for 18 months on testosterone. But I'll also tell you that I started on the Testagel on a lower dose, which is the 2 pumps that Mary's talking about here. Holy cow. Oh my God. It is a different world. You do not want large quantities of testosterone in your body. You go mad. It's just, it takes over everything. We'll, like, never mind the periods thing. That in time will disappear. This is a marathon, not a sprint. I have to say that. But if you are, like, your libido is going to jump up by about 500%. You do not want that even higher. And something like libido, which is a 3-month injection, you cannot get off the bus. You can't get off the bus. This stuff wakes you up in the middle of the night. I'm not joking. You can't sleep. You can't, like, honestly, those things they say about teenage boys, you just become one. It's terrible.
No,
So,
I had a patient who literally couldn't go to work. They couldn't focus. They were, and that was, I had to bring them down to a half or quarter of compression of Testagel. So you're right, Ray, it can have.
Oh my God. It's unreal. It took a long time to get used to it. And then going from that at sort of 10 months to sustenance, a whole new level came in that I thought the last one was bad, but dear God. So you just don't want, you've got to be able to focus and go to work. Like, you have to, like, honestly, I can't even begin to tell you the difference. So so take it easy. I know you're desperate for your period to stop. I know you're desperate to sound male and pass and grow a beard and all this kind of stuff. You know, puberty is 7 years. You're not going to achieve that in a year. It's unrealistic to think that you will. Don't listen to the timelines. They're not telling you the truth. I'd rather tell you the truth. So there you go.
We've got a question in from Kat, who's asking just that, actually. Are there other benefits to microdosing testosterone rather than taking the full dosage? Do you think it's more of an easing in sort of thing?
I think, you know, some patients require that, others don't. And that's the interesting thing, actually, Jess, because I've always wondered why, you know, with testosterone, you know, everyone goes bang on in big regular kind of doses, the way, you know, actually patients will end up now. So, okay, so in an assigned male at birth, testosterone levels will range anywhere from say 7 to 33. Now, in fairness, most of them are in the teens or the early 20s, kind of averaging around there, and 7 is low. But, you know, I've always been amazed that we kind of give this full dose, but we don't do that for trans female patients. We gradually introduce estrogen. So, you know, as Ray said, maybe there is something into, you know, maybe going in a wee bit slower with it. But in fairness, you know, I've only probably had about, in the last 6 years, I've probably only had about 2 patients who've struggled over 2 years, 3 years, you know, for voice changes and things like that. And I'm always amazed that actually that my trans male patients adjust really well. You know, they don't. As I say, 99, it's only the 2 patients with psychosis that had issues. You know, most of them do incredibly well. And it amazes me because it is such a powerful hormone. And I do say to patients, you know, you can get angry, you can get irritable, you know. If you're used to crying, testosterone dries the tears up. You know, I used to think it was a male thing. You know, at my late age, you know, I've realized actually it's bloody testosterone. You cannot. So I say to them, if you're a crier, you know, and you're used to expressing your emotions that way and you can't, then you need to get a punch bag because you don't want to be taken out on people around you.
You know, listen, I was never a crier, but I could cry. Like a sad film, to be an odd tear here, not like nothing. I go, oh, there's a sad part coming up. Don't care. Like literally, like the ability to, I feel it sort of, but nothing like I used to. Like there's a lot to get used to here. You know, when we were talking with the ladies going on estrogen, and they were right, and they were saying that the first 6 months is emotional. It's an emotional change. Well, guess what? There are physical changes, you know, from, you know, FTM, but there's also an enormous amount of emotional changes as well. And it's a new order, and you have to get used to the fact that, you know, you're going to be a lot more direct. You're not going to be pussyfooting around people. You're going to be a lot less empathetic, you know, and it's not that you're not a nice person. Your personality has changed. It's just, you literally will start to see the world in a different way. And I can't even begin to tell you how different that is, because you've got to adjust to that. You know, the way that you behave is literally going to, people are going to say to you, what happened to you? You used to be so nice, and now you're just like, you know. And it's purely the testosterone. And if you go in with a high dose of testosterone, that's going to be a lot worse. You know, people are going to stop talking.
And of course, complications can occur as well. You know, you have to keep an eye. You do have. It's important once you stabilize on, you know, testosterone in the first 2 years. That's why we do the 6-month T-gel. Then patients want to move on to Nebido. You know, I have a few patients on Testosterone. I do, in fairness, because I started them many years ago. They still come back and see me. Wouldn't be my favorite, but it works. But you know, that's why we review patients for that initial 2-year period, because if they're stable then and their bloods are all okay, generally they don't have problems unless they have, you know, other comorbidities or conditions which impact, you know, their endocrine system. They don't tend to have problems after that stage.
Okay, so we're basically talking about a transdermal gel, which is Testogel. There's 3 or 4 different versions of that, which is like
there's Testosterone, there's Testogel, there's the sachets, there's the pump. Yeah, there's a few different.
Okay, and then we have Testosterone, which is an injection that is basically once every 2 weeks to every 3 weeks, depending on the dosage that you're on.
Yeah, short acting,
which is what I was on, and I would say I loved it until there's none of it anymore. And then there's the Nebido. Now I have to say Nebido, which is a longer term, it's a 3-month injection on average, isn't that right? So your T rates are very high at the beginning, and then they kind of taper off towards the end.
Well, interesting, because it's a slow release, long acting. So there's, if you were starting on it today, because it's a slow release, we get our patients to continue, say, the gel for the first 2 weeks. And at that stage, Nebido is kicking in. But there's a loading phase. So you'd have 1 today, 1 in 6 weeks, and then you'd go on to every 12 weeks. After the second injection, 9 weeks after, we get patients to check their bloods. We want to make sure that everything is okay before they have the 3rd shot. But I have patients who only need to have a Nebido injection every 14, every 16 weeks. One of them is every 23 weeks, you know? So it very
And
much
so what sort of
depends.
levels are there, is there T at then? What
Well,
to you are
well,
you trying to aim for?
it's not, you see, libido, unlike Testosterone, where with Testosterone, you check your peak 7 days after your shot, and you check your trough, your blood level, then the day you're due, you have to have your shot. Okay, now, with libido, we will just check a trough, because we know the level's going to go up a bit. But let me tell you something. I've had patients on Testosterone, and, you know, some patients, bless them, they get a bit mixed up because, you know, you're giving them a lot of information. So instead of having their blood test done for their trough level before their injection, they'll have their injection, have their bloods taken 15 minutes later, and their T level will be up over 80, some of them over 90. Yeah. So because it's an intramuscular injection, you know, it hit the bloodstream and it's fast acting. Okay, it's absorbed really quickly. You know, their level can go sky high. And I've had patients say to me, Mary, I felt like I could run a marathon. Mary, I thought I could fly. Now, if you have someone who, you know, is slightly unstable, the last thing you want them to be doing is flying. You know, so that's why my preference always start on the gel, move on to libido, slow release, long acting. The only problem is testosterone stimulates the bone marrow to produce a lot more red blood cells. It can do in some patients, and you can end up with a kind of an overcrowding. Okay, too many red blood cells.
This is the thickening of the blood.
Yes, polycythemia. So, you know, that's why I say for the first 18 months in libido, just need to keep an eye, because that can be a problem. And the last thing, you know, I say to patients, I won't put you on libido if you're a smoker, because if you're smoking and you're inhaling nicotine, then it actually even makes the blood cells stickier. So it's more likely that you'll get a clot or have a problem. And you should be drinking at least 2 liters of water a day, because you're like diluting the system, you know, it's like diluting orange squash. So, you know, if they kind of do what they're meant to do and stay fit and well and healthy and avoid smoking, things like that, they shouldn't have problems long-term at all on libido or on anything.
Yeah, because in fairness, when I read the side effects for libido, I was a bit like, oh, that doesn't sound great. You know, and again, you can't get off the bus if you're halfway down the line there. But you're saying that that's really not to be worried about.
If you read the side effects of any medication you're about to take, you know, everything gets thrown in there just in case. Because, you know, pharmaceutical companies, you can understand it. You know, they're kind of, you know.
Yeah. Okay. And so I know I can see the questions mounting up and up and up here, but I'm still going to ask more just in case we answer some of these at the same time. So if for people where testosterone is not really stopping the monthly cycle, or just the T level isn't really doing its job, do you ever prescribe blockers?
Yes.
Okay.
We do.
So what?
But in fairness, very rarely. And, you know, it's, again, you know, one size doesn't fit all. If we have someone who comes back at 6 months and they've still got a cycle, the first thing I'll do really is, well, it's good actually that they're cycling, because you know that, you know, okay, at least they're shedding the endometrium, okay, because estrogen, when you're having a cycle, what happens every month is, and this is from my midwifery years, you know, what happens is you get a buildup of blood in the lining of the uterus, which is called the endometrium. And what happens then, say, if you don't catch, you don't get pregnant or whatever, the little oocyte isn't fertilized, then you shed it. And that's quite normal, okay? Now, if you're doing that, you don't get a buildup in a bulk. And it's fine. Now, if patients come back at 6 months, they're still menstruating, I say, look, okay, the easiest thing to do is to start you high on libido, because, you know, I do find in 80% of patients you put on libido, because if you think of it, you put your Testosterone on in the morning, your level's going to go up. As the day goes on, you have that diurnal rhythm. So you may not be having a steady enough level to suppress ovarian function. So if you put someone on libido and they're getting a kind of steady level, 80% of my patients, even more, they'll stop menstruating on libido and they crack on, and you see more changes and everything just settles down. If it doesn't, and they're still menstruating, I'm thinking to myself, is there some underlying pathology here as well? So I will write to the GP and say, you know what, before we do anything, let's just do an abdominal pelvic ultrasound and make sure that, you know, there's nothing else going on that we need to know about before we do anything else.
Are we talking about fibroids and endometriosis and stuff like that?
You know, and you know, patients can just have a buildup of the endometrium regardless of what's going on, because we know testosterone can convert to estrogen, and there's multiple things that could be going on, but I always want to know that the underlying pathology is normal before you do anything else. Now, say they're on libido and they don't stop, and they're not sexually active, they don't need contraception. But sometimes the easiest way to stop the menstrual cycle, and indeed, the cheapest way for a GP to do it, and, cost is important if you're, because all GP practices now, they have a budget. So the cheapest, easiest way sometimes to do it is to say to patients, look, you could start on the progestin, not the progesterone now, because that's body identical, the progestin only pill, like desogestrel, 4th generation contraceptive pills. And again, in probably like 70% of cases, maybe more, menstruation will stop. So, but sometimes patients like, oh, Mary, I don't want to take that. But then you're looking at the Depo-Provera injection. And that is a contraceptive injection, again, a synthetic progestin. And you would have that every 12 weeks. Now, my experience of this, being a family planning nurse as well for many years in general practice, is that you can sometimes put on the kilos with that. You see 2 kilos gone on this year, another 4, and it can get a bit. And with the appetite increase with testosterone as well, do you really want to lump that on a patient? Nah. So the other thing, of course, then you can look at, if you have a slightly older patient, you could look at the intrauterine contraceptive device, Mirena, the coil. There are lots of different things, but, the most expensive is the injectable blocker. But, if it comes to it, of course, we will do that. Because would you like to be having a regular menstrual cycle now, Ray?
No, I mean, look, here's the thing. I never wanted a menstrual cycle, as nobody ever did, but I was also 46, so perimenopausal, so they were kind of not really a thing at that point anyway. Less so. So literally the second I took any testosterone, that just disappeared out the door.
And it does for some patients, yes.
It like almost immediately it just disappeared out the door. And then all the other stuff started kind of happening, the bottom growth and, strength gain and that kind of stuff. That sort of stuff happened, but nobody else really noticed it except me. Like it wasn't noticeable to anybody else until I was about 9 months. And people go, a cold. Like, what's going on, Dave? You got a cold? No, my voice is breaking. And then the next successive year, they just spent laughing at me because my voice would crack and break and I couldn't sing. And I could never sing, but I really couldn't sing. Like Happy Birthday or anything like that. That was always very interesting for people. But for me, it ended up, but my T levels did drop down quite low at one point, about 9 months in, I guess. And I could start to feel things starting to cycle again. And I didn't get a cycle, but I got a period pain and I'm like, hang on a second.
Yes.
Hang on, this is not going to happen.
No.
And so I talked to my specialist and they just went, yeah, Testosterone, let's get you on there. And that's sorted out. There's the levels were like below pubescent rates, where just the way it is, sometimes it happens like that. So and the questions are coming fast. I mean, we have
some.
Yeah, I think I don't know, will we do it in sort of the order that we've been given? Because we're kind of talking about sort of bloods at the moment and the question that John had first. Do you want to ask it or will I just read it out now?
Let's go for it. So what sort of bloods are we looking at taking, Mary, when you're taking testosterone? What sort of stuff are they monitoring?
Well, we do the initial screening bloods before you start. But basically, I don't believe in taking bloods for the sake of it. If there isn't a clinical indication or a reason to do it, I don't like asking GPs to be spending, I don't like waste, end of story. So literally, ideally, your testosterone level, and if you're on gel, we normally say if you can manage to do your bloods about 4 to 6 hours after. If you're on Sustanon, yes, you can do your peak and trough. But if you've been on Sustanon for years, you and you're everything is okay on it, you don't need to be continuously having this idea of having blood. Postmenopausal females on hormone therapy for 20 odd years never have a blood test. You don't. Once you're steady and stable, and it is in that first 2 years, getting everything sorted. But we like to see your full blood count in the early days, because again, we talk about polycythemia, we talk about, your red cell count going up, your hemoglobin going up, your hematocrit level, which measures the viscosity of the blood. These are things that can cause in an assigned, because our trans male patients are assigned female at birth. So it takes their body time, to build into that kind of male, masculine body that can cope with this extra. So you do have to be cautious initially. So I would say your testosterone level, your full blood count, most importantly. Initially, in the first year, 18 months, check your liver function test. But it very much depends too.
What about the estrogen
John,
level?
answer
Would you
the
not check
question.
that as well?
Sorry, say that again.
The estrogen level, would you not check
Yeah,
that as well?
Yeah, we do. But it's not a thing I would continue to do, because look at it here. Do you know, I think far too much testing is done. And I'm not blasé about anything, but it very much depends on the patient. Having the conversation, how are you? Are you well? Are you having cramping? Are you bleeding? Is there any indication? The latest research shows that, I used to say to my patients, I remember sitting in a lecture about 4 years ago, and it was a consultant obstetrician and gynecologist, and he had taken 12 trans male patients who'd been on testosterone, injectable testosterone, for 2 years, and he biopsied their uteri, and in every case he found atrophy. So, I thought, oh, well, God, this is great. But the latest research has actually shown, I was only reading these papers like a few weeks ago, that actually 50% of trans male patients will still have, some endometrial action and activity there for quite some time. So it is something that we should be aware of. But, if patients are not having if there's no history in the family of, uterine, ovarian cancer, if they're not cramping, if they're not bleeding, if they're comfortable when they orgasm, when they're having, when they're sexually active, when they're having venovaginal intercourse, if that's all comfortable, well, why would you be continuing to do tests that aren't necessary? It very much, and that's
Once
why
it's stable.
I always say I'm shocking. That's why we like to spend time with our patients, have a conversation, and understand how they are. And it very much depends on the patient.
Yeah, I mean, I think the general consensus for blood tests is every 3 months for the first 6 months, and then if everything is stable, then every 6 months from that point onwards, and then every year once you get to 12 months. Now, I did it a little bit more. I did it every 3 months up to a year, because I knew my levels weren't stable. And now that I've changed the system, because there was a change in what I was taking, I wanted to see if that made a difference. So I continued to do full bloods, estrogen, liver, and obviously T levels as well, because I had changed and I wanted to see. Now that's 6 months ago. Don't need to know anymore, because I know how I'm feeling. I know.
Yeah,
I know things are fine.
And this is, if patients contact us and they say, do you know what? I just don't feel like it's right. Excuse me, something's not right. Well, then, of course, we'll write to the GP and say, can you just check, and we'll see. Absolutely. But, I think for me, we do regular blood tests every 6 months for the first 2 years. If everything is stable, then you can go on. Do you need to have annual blood tests long term? No, you don't. If you're all right, if there's any problems, yes, of course, they need to be investigated. But I know some patients are more anxious, and, we understand that. We have a conversation. Sometimes it's just about reassuring the patients. But if there is a clinical indication, that is when we will action it. And you're right. Some patients may need to have their bloods checked if they have, other comorbidities, they're taking other, polypharmacy, multiple medications, 3 months in, absolutely. But for the majority of our patients, 6 months is absolutely fine.
Right. Okay, good. I think I agree with that. I mean, at the beginning, I was just being careful because I was older, and because I was older, nobody knew who would work on me. Somebody my age was too old. Rubbish. It's rubbish. So don't listen to that stuff. There's so many myths out there. They're all bloody wrong. Which ties into the next
segue. Yeah, very great segue. Mary, what sort of age range do you see for your female to male patients at the clinic? I think I know the answer to this question, but I would like to hear you say it.
It's actually that now, do you know, you're making me think, Jess. And I've done that since 6 o'clock this morning, and it's getting, I'll tell you, it's getting more difficult now. But we don't see patients under 18, you know, I would say, unfortunately, lovely. But, you know, I'd love to start seeing the patients at 17. But, you know, anywhere from the age of 18 up to, we have patients in our 60s, you know. Interestingly, I have more older trans female patients than I do trans male patients.
That's interesting. That's interesting. I mean, I know when I was looking for information on older, because I didn't know, like, you're stepping in, like if you're 18 or 19 or 20, there's loads of timelines out there. But when you're my age, there's like one. Now there's me, there's two.
That, you know, that is very interesting.
Yeah.
And, you know, you wonder, is it because assigned females at birth, maybe they just become,
you know what? I see a lot of them around now. I see a lot of them around now, but at the time they're just not visible. And what they're not doing is they're not doing timelines. That's the difference. They're just getting on with things. They're just going, come on, I'll get on. I don't need to make a video about this. I'll just get on with it. I think that's the majority, because
all become, as we age, we become more androgynous anyhow. So, you know,
but that's not the aim, you know. For this,
I know. Will you give me a little bit of leeway?
Sure, absolutely. But I mean, certainly having run the trans group, a lot of the FTMs that come to us are in 30s, 40s, 50s. A lot of them. Yeah, we do get the younger ones as well, but less so. So there you go. They're out there.
I would say that probably 60% of my patients are under the age of 30.
Really?
Yes.
There you go. So they're just I guess the people who apply to the group and stuff like that. Well, but that's still a reasonably mixed. I mean, you know, 60% is still 40% of people who are over 30.
Yes,
you know?
yes.
So that's still a reasonable number, you know. So anyway, like all these questions, how long is a piece of string, really? You know, it just depends who turns up.
Absolutely.
Now another question has come in. Will I take the next one in here? Because then the ones from Leo, I might just take them myself. But how long does it take? This is where you get your magic ball out, Mary. How long does it take for testosterone to take effect?
Well, now, actually, my crystal ball, this is what I say to patients. You know, I stick my head under the desk. I won't do it now, okay? And I do have, one of my patients actually did bring me in this beautiful glass globe. And I think it's almost like a jellyfish in it. I must find it because I know it's in the practice somewhere. I must use it as my crystal ball, because that piece of string you were talking about, Ray, it's impossible. You know, you look at any, you know, assigned male at birth going through puberty and you compare them. You can't. You know, my son gets embarrassed when I talk about him, but I mean, when he played rugby at the age of 16, he looked like a 12-year-old and everyone he was tough as old boots, full of muscle, but not a bit, not height in him or not a hair on his face. And yet his friends were like, could be 6 foot with beards. So everyone is different. And yeah, as Ray said earlier, don't compare yourself, because you're not doing yourself any favors. You know, just let nature take its course. As long as you're safe. As long as you're safe and, you know, things are happening, be they slow, is the most important thing.
Nobody wants to hear this. Nobody wants to hear that you're not going to get all, because all the timelines are up to a year, and after a year, you're supposed to be done, right? No way. I've had more changes after a year than I had in the first year. Okay. It's
what did your first year look like? Can I ask?
So my first of all, we'll just get over the panic of taking it in the first place. And I thought, not that, you know, the fear of, I'm going to change my life enormously by putting this on my chest. Dear God. Like, when I think of the mindset I was in at the time, I just, it's laughable. I started noticing stuff on day 3, and it's very unusual for that, but I got it. And what I mean is, tingling in the bottom growth area. All right. That hit me fast. Libido within a week. Oh my God. But I also calmed down. You know, I was being very anal about everything. You know, it's like, I must get exactly the right amount on my hand, and I can't waste anything, and I can't touch my dogs, and Don't touch your dogs if you've got wet testosterone on your hands. Don't do that. Or anybody else for that matter. It transfers. So don't do that. So I noticed within a week, I started getting a sore throat. And for the best part of well, really up until about a month or two ago, if I look down, it felt like something was cutting my throat here. I've had a sore throat for almost 2 years. And I mean laryngitis, like type of sore throat, where it hurts to talk. And I remembered about 6 months thinking, oh, Jesus, this sore throat's just not worth it. But it is worth it. Now, I could hear the changes all the way through, but nobody else could hear it until about 9 months. When it's like, are you getting a cold? Like, that's what I got. Now, in that period of time, within about 3 months, I was able to lift significantly more. I would say about a third more in weight than I could. And yeah, I was working out, but I'll be honest with you, I'm not a bodybuilder, never will be. Okay. But I could eat, things are just much easier to lift now that I don't even think. Stuff that I would have called heavy, not a problem. My ability to recover after exercise. Whereas, if I'd run 200 meters, I'd be curled over for 3 minutes. But on T, I'm ready to go after 20. Like your what is that called? Not longevity. Stamina. There you go. Simple word. It goes up enormously. I got more hungry, but you cannot eat more. I'm sorry. You're just going to have to deal with that one because you will put on weight. Testosterone people put on weight because they suddenly want to eat pizzas and drink loads of beer and eat chocolate and all that kind of stuff. It's going to be quite a while before you can, as the question came down here about, taking the nutritional advice for a signed male at birth. I would say almost never will you be in a position to do that. You just won't. So that sort of physical changes. At about 6 months, I got a little teeny weeny bit of hair in here, but then I started helping with minoxidil, which frankly has worked enormously well. And I did that because my brothers, at the age of 28, not a hair between them, couldn't grow a beard to save their life. But in the space of about a year, 18 months, I've done quite well here, and I've outpaced everybody else in our group. We've got, a guy in our group who's been on T for 6 years, and no, he's got a little bit of fuzz up here, and that's about it. So I wanted, because of my age, I wanted to kind of hurry that stuff along. There's another question, I think the same guy, on emotional changes, significantly less emotional. I'm not worried about hurting people's feelings anymore. If I've got something to say to you, I'll say it. I'm now renowned on being extremely more direct than I was before. I'm not unfeeling. I'm not unempathetic. I do remember what it's like, but I have to think about it. I have to go, oh, that's why she's crying. Why is she crying? I don't know. She's crying. Yeah. So I have to think about that. And if I hadn't had that experience beforehand, I would be an asshole, frankly. I would, because I wouldn't understand what this is all about. But now I do. And so I'm significantly more direct. People at work give out to me all the time because I'm just like this. So there you go. Can't cry. Don't get sad at films anymore. Laugh a lot more. I'm much happier in myself. I love how I look. Life is great. Does that answer that question?
I think it does. And well done you. But I really hope for everyone around me that I never, ever consider going on testosterone for any reason, because I'm like that now. I'm one of the most direct people. I'm scary. I'm not a scary.
Direct is good, but I never was, you see. I never was before.
Oh, right.
Yeah. So
it does.
People notice.
It does. I hear people say that. And, I see the change in my patients, the confidence it builds. And I see them when they come to their first appointment with their girlfriend, and then they come 6 months later and the girlfriend has said, Mary, you didn't tell me this person was going to change. They don't listen to me now. I might as well be talking to myself. We don't even cuddle that much anymore. Well, I said, I did tell you. I did tell you. You weren't listening.
I take the cuddles now. Don't mind the cuddles.
Right. Well, you see, this is it. Everyone is different. And it's very interesting. But as you say, Ray, it's a very powerful hormone.
It's a very powerful. Give yourself time. Let's honestly, don't rush this. You've got a lifetime to make this play out. You don't want to get it all done. There is a learning process to being in this. There's a whole heap of things to learn. The physical changes are the least that you're going to be going through. It's the mental and emotional changes that are significantly more. You have to learn how to act, react, think. Everything changes. You don't want to rush that. If you said to me on day one, if I could press a button and just change, would I have done it? And the answer would be absolutely 100% I'd have done it. No problem. Would I do it now? In no way. It would have been the worst thing that you could possibly do, because you have to learn, you have to grow, you have to adjust.
It's
And if
true.
you don't get that time is your greatest friend, then you are doing yourself a massive disservice. You've no choice anyway. You can't press that button. But you know,
patients say to me, I say to them, you know, what's been the most difficult? They say, Mary, I go into the barbers and they want to talk about football. I don't know anything about football. You know, I think, you know, the whole, as you say, it's not just about the physical changes. It's the reaction of everyone around you, and you know, and what they presume you to be, which you weren't kind of before, and you know, the social aspects of it, and you know, having been, you know, an assigned female for such a long time, and having that behind you, and then being in a group of males, it's a very different scenario and situation.
I'm still learning.
So,
I'm still
yeah,
learning.
it does,
You are
and
treated differently, and you are treated very differently by women too, very differently.
yes.
So you have to learn. You have to learn. I'm going to stop talking because the questions just keep getting more and more. I think a quick question is probably a yes no one. If you're on a low dose of teas, is there a risk of overall hormone deficiency because you don't have a lot of E or a lot of T?
No, there isn't really, because I mean, even if you're on, say, low dose T, it's likely that your testosterone level is going to be in the male range, even if it's in the low male range. And if it's in the low male range, chances are you're still producing estrogen anyhow. Let us just remember that both males and females produce testosterone, estrogen, and progesterone. Bless you, Jess. They you know, they produce all three hormones, different levels. So, but the likelihood, excuse me, the likelihood is that, you know, your body is still producing enough hormones to, because sometimes, interestingly, and now I know we're not doing non-binary today, and I don't know if we're doing a session on it, but
we are doing this. The next one is
okay,
and actually there's a question here from non-binary.
Yes, there's an interesting one. I'll leave that there. But Jess, did I answer that question?
Yeah, the answer is no.
Oh, thank you.
Simply no. So Joe, I know you've asked a question, but we can talk about maybe a little bit of the microdosing, but we have an entire session on non-binary that we're gonna do here. So and now the question has gone. It's disappeared. What was the question?
We're all fine. We'll cover that in non-binary. Let's maybe get the female to male ones.
Okay, so we will talk about microdosing and stuff, and we'll be very specific on that stuff as to what you want. Okay, so here's a good question. So do you want to ask it? Because again, I'm asking all the questions here, Jess.
Well, the question from Elliot is, how does testosterone affect your fertility? Now, obviously, I know the estrogen side of things and how that works, but how does testosterone work in female to male patients?
Again, you know, that crystal ball I talk about, I cannot predict. You know, the research tells us that, you know, that ovarian function, say if you're on T for up to 2 years, that your ovaries, if you stop testosterone, you know, should, you know, kick back into action fairly fast, really. It shouldn't be a problem. But there's no certainties in life, and we cannot predict how one individual is going to respond. But I do, you know, we do know trans male patients who've been on testosterone for many years, and they've stopped and they've got pregnant, and, you know, and had children of their own biologically. So while I'd say there are no certainties about any of this, because we're all individual, but chances are, you know, even, and the research has shown this, that even when you've been on T for 2 years, and I have patients who, you know, maybe come when they're young and they have a second thought and they think, do you know what, Mary, maybe I would like to have a biological child at some stage, and they'll stop testosterone and they'll go off and they'll go to the fertility clinic, you know, and they're back menstruating within a few months, and, you know, they'll have fertility preservation, they'll go back then on their T, and it's, you know, it's absolutely fine. So I know there's a lot of concerns and worries around it, because, you know, it could be completely life-changing. We cannot predict. We can look at, you know, the statistics, but, you know, we can't treat each other like we're statistics. And I'm always very open and honest with patients and say, you know, I can't tell you, you know, we go through our consent form and I say, you know, this could render you infertile. You may never be able to have your own biological children. And most of my 18, 19-year-old patients say, oh, Mary, I'll just adopt. And I'm like, do you all think that these young kids for adoption grow on trees? You know, are you, so.
Yeah, that's it. The chances of that, a transgender person adopting, that's another subject matter. I think the
Absolutely. That is
completely.
another session for sure.
It is, yeah. And I've never, it's unless in this country, I've never heard of it. So, and once you're over 40 anyway, there is no chance of adopting. So, but from the people I've met who have been parents, their recommendation is do fertility preservation first so that you have it. And if you change your mind, grand. If they never get used, grand. The majority of people who stop taking tea within 6 months are back on their monthly cycle. That does depend on your age. If you're 40 or above, come on, you're perimenopausal. Let's be realistic here.
The other thing to remember is, and that's a very good point to bring up, Ray, is that say you come off tea and you've been on it for years and years and years, and you're getting to the menopause and you're no longer producing estrogen. Testosterone is vital to protect you long term, to protect your bone, your brain, your every cell in your body. So sometimes patients say to me, "Oh, Mary, if we just block." No, you can't just block. It's like a car trying to run without petrol. It don't work so good, and you're putting yourself at risk.
Yeah, that's it. So there you go. So there's a lot of myths around fertility, but most of the time, but look, chance favors the prepared.
Yes.
Really is the thing here. So another question, should we read this one out? Because I think it might also be
we've got a question in from Joe. He's been on testosterone gel for 6 years. He was on 1 pump for 5 and then 2 pumps for the last year. Levels are either through the roof or rock bottom, and he's struggling to get them stable. Now, he says he's getting bloods done after 4 hours of gel application and the results are too high. Is the suggestion that if he waited 6 hours or perhaps longer, the level might be more accurate?
It's not all about levels. Okay. Did you say he's still menstruating as well, Jess?
It doesn't say that.
It doesn't say. Okay. I always say, listen to me. When the girls ring me up and ask me if they have a problem with a patient and they say, "Mary, what do you think?" I say, "How's the patient? Never mind the levels. How is the patient? They're sitting there in front of you. Ask them, how are they? And if they say, yeah, no, they're feeling fine. Look, Carl Neff, who's the consultant endocrinologist at the Dublin GIC, and I hate to go back to the old Irish thing again, but here we go. Carl spoke at BAGAS, the British Association of Gender Identity Specialists meeting, was it last year or the year before? And, Carl says, it's not all about levels. You look at the patient, he's absolutely right. And I'm forever saying this to the nurses that I'm training at the moment. Look at the patient and see how they are. Because if they're well and they're feeling good and they're fine, it's all right. It's absolutely fine. Because, if menstruation, say in Joe's case, if it stopped, it is telling us that testosterone is sufficient to suppress ovarian function. That's if they're menstruating in the first place anyhow. Okay. So, it's you need to know that you're not one detail, not two details. There's more details. It's like a jigsaw puzzle. Okay. You have to put it together and it has to make sense. But, if they're not feeling well and say their levels, they're not achieving levels, I would say with patients on gel, I always opt to put them on libido, and then things settle. Again, 80%, 90% of the time, you put them on libido and all of a sudden they're like, "Oh, thank God, Mary," because they're not going up, they're not going down. You're getting a steady, regular level, and the change starts to, kick and settle and happen. But there's also, androgen insensitivity. Maybe for some reason, they're not absorbing the testosterone. What's going on? Now, that's a specialist field. We deal here with the norm. The norm, what is normal? The psychiatrist said that to me some time ago. What is normal, Mary? But it is about looking at the individual. And I think that what Joe needs to do is to sit down with whoever it is that's looking after him and have a conversation. Yeah. And find out exactly what is going on.
Yeah. I think that idea of just getting a steady dose and then not panicking about these levels. So they go up and down all the time. It just depends on when you take your test. Like,
of course, yes.
I mean, you might be just absolutely fine. And Jesus, Joe, I know you're fine. But to me, 1 pump and 2 pumps is a very low dose. It's to me, but then you just don't know how anybody's going to react to it. So you want
And
faster changes, maybe
again,
that's
you
the
know
way to
what?
go.
Too much testosterone will convert to estrogen. So
Oh yeah, you don't want that either.
no, you'll end up with man boobs, yeah, when you've just
Yeah,
had
we don't want that.
surgery. You know, you don't want to, you don't want that kind of nonsense going on. And you don't want to stimulate menstruation. You know, if testosterone converts to estrogen, you still have a uterus. You know, you could be menstruating away, and the problem is you're putting too much testosterone on. So, you know, it's about finding that safe middle ground where things are changing and you're safe. But if you don't feel well, please don't focus on the levels. If you're feeling well, don't focus on the levels. You know, it doesn't, you know, us females, we don't have bloods done to check what's going on all the time. If you're on hormones, you're feeling good, you know, have your bloods done. If you've been on them for 2 years, have your bloods done once a year if you want. After a year or two, if they're grand, every 2-3 years. You don't need to have any regular.
And there you go. And I think that kind of answers another question here. You know, I'll say it briefly, but I think it kind of answers anyways. I mean, I'm testosterone for 3 months and considering taking injections, but would it be a wise decision as it's not stable, is not as stable as the gel? 3 months is far too early to be making any decisions.
Yeah.
It's far too early.
Yeah, leave it to at least 6 months.
Yeah, far too early. Another very quick one here. How does the GP decide the initial dose? If you don't want me saying they don't, professional does.
No, they don't, bless them, because you know GPs are general practitioners, and I worked in general practice for long enough, and that was some time ago. And they have so much to do, and they're so overworked at the moment, and they have 10 minutes per patient.
And they don't understand transgender at all.
They're you know, they're general practitioners. They're not specialists, and it scares them with all of the media stuff, you know, and anti-trans stuff at the moment, litigation, they worry, you know. So it's best if someone who knows what they're doing writes to your GP and gives them guidance. That's
it. It's under the direction of a specialist. The GPs will not do themselves. If you're lucky enough to have shared care where they will prescribe for you, they simply take the prescription already given by the professional and they re-prescribe it under the NHS, but it's usually you don't get that. So never do that. I think we've already done about the potential health risks of taking tea. It's really just the blood clots, isn't it? And too much creating estrogen, and high blood pressure is another one. I was asking about high blood pressure.
Well, testosterone can increase your blood pressure. And usually the difference is if you're taking estrogen and your blood pressure goes up initially, it usually settles within the year. With tea, if it goes up, you know, it might just stay a wee bit up there. And we know that men are more at risk of, you know, heart disease. But if you look at all of the complications, the long-term complications on testosterone, I mean, it's fairly similar to any assigned male at birth. And as we age, of course, we're more at risk of other comorbidities. But, you know, Ray, as you were saying earlier, you know, it does make you hungry, but it's about eating protein, you know, 5 fruit and veg a day, you know, 30 minutes of moderate exercise 5 times a week. And you really cannot go wrong with that. It's so important. But, you know, if you eat the wrong things and you become obese, then yes, there's an increased risk, regardless of whether you're on testosterone or not, of high blood pressure, diabetes, heart disease, cancer. You know, we have patients with abnormal liver function tests before they ever start anything. And mostly it's because they're obese. Yeah.
There you go. Nothing to do with the tea at all.
Yes.
Yeah. Nothing to do with the tea at all. So a very quick question from Patricia, which I'm going to answer here because I'm a parent and my child is transitioning. Where can you advise where I can find a suitable doctor, surgeons, etc.? Well, surgeons, London Transgender Clinic. But before you do that, you need to get a diagnosis. And if you're waiting for the NHS, it's years. However, there are a list. And if you actually, Patricia, if you just email me, I can send you a link where there is an active worksheet of all the trans-friendly doctors across the UK. It's very, very handy. And it's updated on a regular basis. There's a bunch from East London in there. And that's where I would actually start. But if you're waiting for the NHS, you might be retired by the time that happens. You're probably going to have to go private in the UK at the moment. We hear the wait list in London, they're saying 6 years, but based on another one I heard, it's more like about 29 years. So I hate to tell you that private is the best way to go and you can get on that fairly quickly. But if it's your child, you need to make sure that they know what they're doing and that they've full psych evaluation and that you've really talked about this to them. we have a lot of information here that can help you. We have a lot of contacts, a lot of other organizations that can give you a lot of information. And there are support groups out there specifically for parents of trans children, and they are a fountain of information. So again, email me and I will put you in touch with those people so that you can get the answers. And also, you have a lot of questions. You need your questions answered, okay? You need to make sure that you know that your child is going to be safe and that they're doing the right thing. The only one who knows them is you, and they know themselves. But you need to be very clear and very honest with this, okay? At the early stages, people say all kinds of things that may not be exactly who they are. You have to be sure about this. They have to be sure about this. I'm sure they're saying they are, but anyway, email.
We actually encourage patients to bring family, parents, whoever they want to bring into the consultation. I don't have a limit on how many people are there to support the patient. And, you know, the psychiatrists that we work with, I mean, they will see patients within 4 to 6 weeks. And then it's probably about another, probably 10 to 12 weeks at the moment to get an appointment to see us. So it's not forever.
Which is really good.
Yeah, that's not bad.
That's really good.
We're working on it, you know, we're bringing it.
That's really good.
Training
really
and
good.
educating.
Yeah. So the next one is a quick one. First of all, is a personal note with somebody who's very excited to be meeting you super soon and can't wait. Like Super Mary, basically, is what we're hearing in the chat here. But the question is actually to do with that, is to do with, if I get a prescription, can I get it filled on the same day?
Yes.
Yes.
Now, interestingly, actually, you can, you know, because where do we have a patient from? It came in early this morning. Oh, Lord. Geez, anyhow, it was miles away. And then one of the questions was, how long am I going to be here? Will I get my prescription? Will I get home before the chemist closes? I went, oh, for God's sake, will you sit down first? You know, we have a conversation.
If your chemist has it in stock on the day.
Yeah, but now, because because I'm working for Fitzrovia Hospital, the pharmacist is next door and she's lovely. And I've given her a list, because since the 1st of February moved in here, I've given her a list. So literally, do you know, you can literally leave the consulting room, go down the corridor, and hopefully the pharmacist will have a stock, so you can get it before you even leave the hospital. But you can go, you know, Tesco or Asda, they don't charge you for private prescription. You're paying cost price. I always say, go to your local pharmacy, because if they don't have everything you need on the day, they'll give it to you the following day, because they're generally very good. Tesco or Asda don't charge, well, they don't charge for the private prescription costs, they just charge for the whatever, and then the GP will start prescribing after that.
Yeah, fair enough.
Brand naming, should I? But it doesn't make a difference.
No, it's fine. It's fine. So a quick question in here: is there an associated risk with not having periods? At what point would you recommend patients should have a hysterectomy?
No, I mean, they used to think, and you know, in some countries still, they won't give you gender forming hormone therapy as a trans male patient unless you have a hysterectomy within a year of starting the treatment. You know, you're almost pushed into having it done. If what happens is that your uterus stops functioning, if atrophy occurs, so the linings of the uterus is made up of 3 different layers. The ones mainly we're interested in is the endometrium, the inner lining. Now, you know, if that shrinks because you're not having menstrual periods on a regular basis and everything, my feeling is that your uterus becomes, because in a normal female, I didn't quite, you know, the uterus measures about 5.7 centimeters, okay, and it's a hollow organ, once atrophy sets in, it shrinks. So it's like having an appendix. It's another appendage. If you don't have appendicitis, you don't have it removed. Do you need to have a hysterectomy? No, you don't. It's not a minor procedure. If everything is absolutely fine, then there is no indication to have a major surgery done. Now, you know.
Yeah, I mean, you're not forced to do it in the UK. Some countries do, but where you are forced is for bottom surgery. You are forced for bottom surgery, but there is a practical reason for that, because you were essentially closing everything up. And in order to get back in there, you got to cut it all up open again. So they will make you have a hysterectomy. Some surgeons will do it on, you know, as part of stage 1, but most of them want you to have it done 6 months in advance. But other than that, I've had atrophy. don't even notice it anymore. It's an internal organ. I know some people are very dysphoric about it, but honestly, let it go.
Yeah.
Let it go. It's
Agreed.
not, you don't feel anything, nothing. It's just like, don't be dysphoric about your stomach. It just function. It doesn't have a function that your stomach does, obviously, but that doesn't
It's
have a function. Don't panic about it.
it's like a postmenopausal female. Not all females would have hysterectomies. Yeah. Same thing.
Yeah,
Not necessary.
We
Yeah.
have a question from Zaremba, who's asking about microdosing. They're asking whether the process is any different microdosing than taking, a more regular amount of testosterone.
If a patient comes in and they say, look, I am gender dysphoric, I have capacity to consent, and that's been assessed and all the rest. And they say, but I just want to take it slow. And there's different reasons why patients may want to take it slow. Okay. It may be that, they're in a situation at home where, it might be detrimental to them to move that quickly. Maybe they can't in their circumstances. Maybe it's work. There are different situations where, people want to take it slow, want to see if things change. I had an email from a patient today who I've been looking after since 2017. And eventually they've said to me, okay, Mary, I'm ready now to go the full hog. So it takes different people, different time. And I'm okay with microdosing and starting on small amounts and giving people time to adjust to where it is they want to be, find out where it is they want to be, or if they even want to go there. I don't have a problem. There is no reason in my mind why patients cannot microdose for any period of time that they're comfortable with. Absolutely.
Now, the results that you get as a result of microdosing are different for every person. What I will tell you is that it takes longer for the results, and you may not get what you were looking for on a smaller dose. But what you don't want to do is go too high first, because you ain't turning back the clock. Okay, no. Once your voice breaks, okay, everything else kind of softens up again, but your voice.
Interestingly, having said that, okay, if you look at our trans female patients, they all have a lot of patients have vocal coaching to change, and I do know that you can work on doing it the other way.
We have webinars on that one. And actually, we've done the MTF, and we're going to do the FTM vocal training next week or the week after. So
fantastic.
We got that covered. But you take it slow is the thing. Okay, don't rush anything. If you're not getting the results, up the dose. That's simple.
Yeah.
Keep it simple. Okay. Somebody else actually had a thing about libido and libido, not the same thing. Yeah. Libido is a brand name of a drug. Libido is.
Yeah, I used to, on our follow-up questionnaire, one of the questions is, about, I put on it, asking the patients, any issues around their libido, or whatever. I've stopped asking that question now, because I think it's none of my business. If patients have a problem or an issue with it, they bring it up. It's not about, people don't take testosterone to increase their, my trans male patients don't take it to increase their sex drive. They take it to transition. It's a gender affirming hormone therapy. It's none of my business. So it is not a question that I ever ask. If patients want to, if they have a concern about it, they will ask me. Okay. But I don't ask because it's not my business. But no, they're not. Libido is not the same as nebido. Although when I do my letters sometimes, Google Docs Dictator does not know the difference.
Yeah. Go. Do you want to take the next one, Jess?
Yes. So we've got an anonymous attendee who's currently on libido, and was wondering what sort of trough levels they should be aiming for. And also, since they work abroad on a sort of more regular basis, would you maybe recommend switching to a more topical gel, something that they might be able to get over there?
Yeah, it might be easier well, trough levels. I mean, if you're anywhere, say between, I would say 10 to 20 for a trough, it's absolutely fine with libido. Once your full blood count, your hematocrit level, everything else is fine. It's easier if you're traveling, if you're on a transdermal testosterone. Although, you know, if you're having your libido injection every 12 to 14 weeks, how long are you going away for? You know, could your GP give you something to bring with you? You could always get a medical person abroad to just do the injection for you. Once you bring the instructions, because libido should be given, it's a deep intramuscular injection. It should be given slowly over a 2-minute period. If you give it too fast, what happens is, because it's an oily substance, you need to give the muscle room to absorb. You know, if you give it too fast, what happens is, I find patients come back and say, Mary, my levels dropped. The injection was given in seconds. Of course, it just comes back out. It'll leak back out of the tissues. So, you know, and also you don't want to have, you know, a fat emboli. You don't want to have, so you need to be careful when you're injecting. But it very much depends, either or, whichever suits. But if you're on libido, you're stable on it and it suits you, and you're only having it every 12, 14 weeks, you could get a prescription, or you could get a private prescription, so that you always had some on you. So if you're abroad, you wouldn't get caught out, because you can go into any private doctor anywhere in the world. They'd be happy to give it to you, I'm sure, if you have a prescription.
Yeah, exactly. So I want to get through. There's still a lot of questions coming through, and we're way over time. So let me just see here. Let's just do a few that I think will be sort of a yes or no answer here. On the subject of age, is there any suggestion that T level should be reduced in older age? I'm going to say, until you have the effects that you want, don't reduce the T levels after that, as you want. But if you want to be an old man, be an old man. I won't do it. That's me. What do you say, Mary?
I would say, honestly, I would say the same thing. You know, unless there are complex comorbidities that are affecting you, you know, if there's a high risk of heart disease in the family, there are things that you need to monitor. You need to look after your health. That's very important. But, you know, men age prematurely too because their testosterone level drops off, because you see it in slightly older men. Their muscle mass begins to reduce. You know, their focus, their mental capacity. If you're a physically active person, it really helps longevity. But if you're not, and your testosterone level is dropping off, then it's a minefield.
Yeah, it's the male menopause, basically.
Yes.
You don't want to do it. Don't do it.
Yeah.
No reason for it. No medical reason for it at all. It's not studied very often, but there's always, all the fitness guys are all talking about keeping your T levels up. And I'm telling you, having experienced it, keep your T levels up. Does weight factor into dosage on going on testosterone? I'm going to say no to that one as well, but you might see something different.
No, not necessarily. It's a very individual thing. I find some patients who are, you know, morbidly obese will find it hard to maintain adequate testosterone levels, be it transdermal or injectable. So the plan there is to encourage them, you know, to reduce their weight. And I know that can be very difficult if you've got gender dysphoria and if you like to stay at home because you don't want, you know, everything else that society throws at you, but to encourage them to have a conversation and to try and get them out of that space in therapy or whatever would be my plan of action.
Another very quick one here, and actually this might answer it. This same person is asking, what would you say to a 14-year-old that wants to start on testosterone? You're too young to be seen by the gender hormone clinic, because you need to be 18. That's the first thing to say, unfortunately. But yeah, so what you would need to do is and the first step is basically is you go to your GP and you get referred if you're going to go through the private system, but you can self-refer to a private clinic. Okay, so if you're going to a private clinic, which I would do, you're talking to a child, because I'm telling you, going to the GIC is a nightmare. They're going to be in their 30s before you get your first appointment.
And things are changing. Sorry, Ray, for butting in. Things are changing with the adolescent service in the NHS at the moment. Everything's evolving and changing. So, you know, I think change is good. I think it may be incredibly positive. But you know, it's a kind of wait and see thing. I do know that there is a lovely and I can give you the name of this gentleman. He's a gender specialist psychologist who worked. Oh, sorry, someone's coming. Someone's just walking in there by accident. But it's okay, no worries. I'm staying for a little while. Thank you.
Security has come to turf you out.
They've come to chuck me out, and I think there's someone looking for me. But Yes, and he worked in GIDS for many years, and he now has a private practice. He's a wonderful practitioner, and he sees younger people for diagnosis and therapy, and he has other practitioners that work with him. So I can give you those details so that you have them to pass on, Ray.
Yes, great. That would be marvelous to pass on. We know quite a number of people, again, who can help out on that. Really, the best thing to do is to go privately, because you get much better care and you have control over that. Okay. It's 50-50 the care that you will get under the NHS system. 50-50 at the moment, unfortunately. I've seen many terrible stories and some great stories, but you don't want to be the one that gets the bad ones. So use the support that's available out there. You'll need to go outside of that. And look, the gender hormone therapy clinic is an obvious one here. There's a reason why we're talking to Mary. You know, we know how good she is.
Because she's the best.
She's the best. She may not
no.
call herself an expert, but she's the best.
No. You know, I wish there were more practitioners out there who could do what we do, you know, and enable patients to access care. I never set myself up as the best or an expert. I just say that, you know, I know what I'm doing and I care. I care about my patients.
So
I care what I do.
You do, and you care, and we love that, Mary. That's one of the best things, you know, is that you have that bedside manner and you actually care. It's not just a conveyor belt system, you know, which unfortunately pervades in other places. A very quick question here, which I might shut down a little bit, is can you talk a bit more about the options to prevent vaginal atrophy? Don't worry about it.
No, you know what? It's like, again, and I hate talking about postmenopausal females, but some females will struggle with it, some won't. It's the same with my trans male patients. Some 2-3 years in will have a problem, okay? Others will never have a problem, but you don't anticipate it's going to be an issue or a problem. But if you have the problem, I can tell you it's easily treated. Okay.
Yeah.
And I do prescribe for it, and it works incredibly well. So it's not something that
we're talking about an estrogen cream, basically, here.
Yeah, there's Ovestin. It's a vaginal estrogen cream, and there's something else, because I was reading on the British Menopause Society website that they recommend now as well, something slightly different, but it's a very gentle estrogen cream. It's not going to stimulate any, you know, feminizing changes, and it's very local, and it works incredibly well.
Yeah, so no need for hysterectomy. That will do the job. A very quick one here. Any forms of birth control that are more recommended than testosterone. Testosterone is not a birth control hormone.
No. We'd recommend the progestin only pill, or very much depends on, you know, your situation. It's like you go to a family planning clinic, you take a history, you see what's going on, how regular are patients sexually active. You know, you want to talk to them about safe sex. Yeah. You want to see if they're on PrEP, you know, lots of different situations and scenarios. So there's no one size fits all. It's about having a conversation, making an assessment, and then deciding with the patient what's going to suit them best.
Yeah. Right. Last one. Do you want to take the last one, Jess? This is question number 46.
So there's words here I don't understand, but I'm sure you two will. On the subject of fat emboli with libido, how common is it? My understanding that it's transient, but do you have any more information regarding this?
Yeah, no, I mean, I've certainly over the last 5 years never seen it. There are risks associated with injecting any substance into anyone, but because, and indeed, Testosterone is a lot more viscous than Nebido, but you're only talking about 1 ml with Testosterone, whereas with Nebido it's a 4 ml injection. Okay, so the plan is that when you inject, that you make sure you withdraw before you inject, so you make sure you're not in a blood vessel for starters, and then you inject. And when I was taught, and it was interesting, you know, when I work with younger nurses now, they've never given an injection when they all right through their training, because most things are given intravenously now. But the injection should be given in the upper outer quadrant of the upper outer aspect of the gluteus maximus muscle. I learned that when I was 18. I've never forgotten it. It was bet into me. But, you know, and you know, if you take your time and do it slowly, and I lie my patients down, make them comfortable and have a conversation, and they don't even know they're having the injection. Okay, you do it slow and everything is absolutely fine. So the risk, I would say, is 0.0, maybe 1%, something like that. You know, it's a small risk, but the bigger risk, Jess, is that if you rush it and you're injecting 4 mils into a muscle, and you're talking about trans male patients who have developed more muscle, so they're more muscular, you know, you have to create that space. The tissues just don't absorb it in seconds. And what I do find is patients will come back and they'll have a low trough. And I'll say, okay, tell me about your injection. And they'll say, well, Mary, there was a load of leakage afterwards. Well, of course, if it's given too fast, you will get leakage. So of course your trough level is going to be low because you've lost most of your dose at the time of injection.
Slow and steady. That's why you know, you can inject the Testosterone on yourself, but the Navita, they never let you. I do it myself. I don't anymore because there's no Testosterone at the moment. And that is, by the way, a supply chain problem. If anyone else knows why there's no Testosterone.
Well, actually, interestingly, is it a supply chain problem? Or is it more to do now with, because I was watching something before, because I thought this question is going to be asked of me, and because I don't prescribe a lot of Testosterone, in fairness, you know, thank God, because we'd have an awful storm coming our way if we did. But you know, they say it's about how did they say it? It's about government and the health service.
Yeah, so basically the two things happened. Number one, the managing director of the company got killed in a motorbike accident over Christmas, and that threw company into a bit of a what are we going to do now? But more importantly, what's actually happened is that the company that makes it in their US manufacturing plant, and they have been contracted by the government to make COVID-19 paraphernalia and drugs and stuff like that. And so the manufacturing of testosterone has been reduced to accommodate the government, US government. Thank you, US government. That's why it's happening. It's to make COVID-19 stuff.
But actually, you know what? I remember phoning a company. There's manufacturers of Testosterone in Ireland, actually. And I was
the same company.
Is it the same company?
Same company. I looked this up.
But the other thing is, why are we not using testosterone cypionate, which is a subcutaneous injection, slower release in the UK? It's available in the US, and I think it's a much better method than.
It's also it's also out of stock at the moment. I looked that one up too. So I've had to go back on the gels because there's no Testosterone available.
Well,
personally.
You know what? At least you're safe. Yeah.
I'm safe,
there is an option, which is great.
Which is great. Yeah. It took some convincing of the GP, but we did eventually. Anyway, there we go. That is 46 questions answered by you guys and a bunch more by us. I hope that this was beneficial and helpful for you. I know that this went on longer than well, they always go on, really.
Yeah, I'm going to be
people ask so many questions. Yeah, we've been tossed out now. But listen, Mary, thank you so much for your time today. Thank you for giving us the benefit of your expertise and experience. It's been absolutely wonderful. I'm glad we were able to help so many people today, and those who are watching the recording of this, if you've made it to this stage. So look, thank you all for taking part in this. Thank you all for signing up. Thank you all for supporting us sort of within the trans group and Trans Matters. If you want to get in contact with Mary, you just go for the gender hormone clinic. You just put that into Google, she'll come up. Okay, and they'll take very, very good care of you. If you're still not sure, go for the London London Transgender Clinic, which is where you used to be attached to, but they will definitely be able to send you Mary's direction. Okay, thanks. So please get in touch, get all the answers, get the proper information that you need. Don't be buying stuff over the internet and self-injecting and guessing. Don't do that. That's a disaster. So
Reddit is not the place for medical information.
Reddit is not the place for medical advice. Neither is a Facebook group. Okay, get the proper information, and you keep yourself safe. That is the most important thing. But again, Mary, thank you so much for the second one.
You're welcome, guys. Lovely to join you this evening.
Yes, thank you. As always, I talk far too much, and thank you, Jess, for guiding us and keeping us on track as well. It's absolutely brilliant. Super, guys. So look, whatever you're going to do, enjoy the rest of your day. And until then, take care, everybody, and we'll see you on the next one. So take care.
Take care. Bye.
Cheers, everybody, and goodbye. Take care. Bye-bye.
Thanks so much for watching. Please subscribe just so you won't miss out on anything we do. Thanks so much.
Bye.